Hello and good evening or good afternoon, depending on where you are in the world, to everyone who is watching today. I had to get Professor Bruce Patterson back with us because at our recent long COVID conference, we had some internet connectivity, and some of the stuff that he was saying was so fascinating that I thought it would be an injustice not to bring him back and explore some of the thoughts and the ideas and the research that he has been doing. So we are very privileged to have him with us. He is an associate professor who used to be at Stanford. He's now the CEO of IncellDx. And with that simple, short introduction, I will bring in Bruce. How are you, Bruce? Are you doing okay?
I'm well, Philip. Thank you very much, and I appreciate you having me back to correct the technical difficulties we had last time.
Excellent. And so here's a question for you, Bruce. You're a virologist. What made you interested in that?
Well, that's a great story. My aunt was one of the first women virologists in the 1960s and early 70s. And I remember being about 17 years old when I visited her laboratory in Chicago, and she took me into this very large room that housed a electron microscope, and we had a sample that we wanted to look for the Norwalk agent, which now we all know as norovirus, the quote cruise ship virus. And for the first time, I6 a viral particle in real time, in real life. And at that point, I was sold. I mean, I think very few people go into medicine thinking that they're going to be a pathologist and ultimately a virologist. But for me, that was it right there. And then, looking at various papers, Michael Oldstone, even Tony Fauci, all these great virologists, people working in virology, were MDs. And I said, that's the path for me.
Wonderful. And so that work brought you as well into contact with HIV when you were working quite early on with
Yes.
HIV. What was that like in the early stages? Was that quite challenging?
Well, you know what? There's a lot of similarities to what we're going through here, which is why I think, we're uniquely prepared at IncellDx and through some of the stuff that I've been doing, uniquely prepared for this pandemic. But early on in HIV, this is the late 80s, early 90s, people were saying that AIDS was not a viral disease, that the finding of the virus was unrelated to the destruction of the immune system. And that's when we all became viral hunters, if you will. Where is the virus? How much virus is there? What is it doing? Is it in cells? Where is it? And this description literally could be about COVID. And so, I used almost the identical strategy that we used in HIV to find, persistence of COVID in long haulers, and we used a lot of the strategy looking at how the virus affected the immune system in acute COVID, because what we learned in HIV, there was a chasm between the virologists and the immunologists, and it was really when they all came together and said, "Hey, let's work together because it's one disease," that we got to a place where right now we can look at it as, yes, it's a viral disease, but it's causing profound immunologic abnormalities. And then, of course, our research showed that acute COVID and long COVID are completely different immunologically. And again, we've gone on from there.
So before we even go into the details with COVID, what mistake do you think we're making now from a scientific point of view that would mirror what we had done with regards to getting lost with HIV in the early stages?
Well, again, looking back in hindsight's 2020, and when you're in a pandemic, there's a sense of urgency. But much like HIV, it all starts with diagnostics. And in HIV, the first quote antibody tests in HIV had a very interesting performance profile. They had a 99% negative predictive value, which means if you got a test report back that said you were negative for HIV, you were truly negative. Unfortunately, the HIV antibody test, the positive predictive value was 20 to 30%. So when you got a report back and it said positive for HIV, only 20 to 30% of those individuals were actually positive. Then that precipitated obviously the use of a confirmatory test, the quote Western blot, to confirm that indeed you did have HIV, and that had really high specificity and really high positive predictive value, a little bit less sensitivity, but the combination of the two tests gave almost 100% accuracy of that result. So, it all started with the diagnostics. I mean, with tests that were suboptimal, but we needed them. But you were dealing with both false positives and false negatives. And what I found from running, the clinical lab at Stanford is it was very difficult to triage patients to either therapy or go home or go to the hospital based on tests that you knew had 10 to 20% false positives and false negatives. And I think, it is what it is, but the fact is we're in that quagmire. And I think it's, the other thing about testing is everyone talks about the performance of the test basically on virus that you put into a test tube. Okay, that's called analytical sensitivity and specificity. If I put COVID in a test tube, how often can I detect it and with what specificity? And those numbers are really high, close to 100%. The problem is in medicine, we deal with clinical sensitivity and clinical specificity. And that involves everything from sticking the swab up your nose to, the drive-ins that you go to, and what is that sample sitting around for 2 hours? Is it sitting around for 8 hours? Is it in the sun? How is it transported? I mean, all those pre-analytical elements go into the calculation for clinical sensitivity and specificity. And almost to an assay, the clinical sensitivity and clinical specificity is going to be worse than the analytical sensitivity and the analytical specificity. So from day one, we were already behind the 8 ball from the diagnostic standpoint. We needed it. They were functional, but far from perfect. And, that was an issue. And then the other issue was trying to think of this early on as a virologic disease, which quickly went to an immunologic disease with not having a precision medicine diagnostic to tell you where are you in this spectrum. Yeah. And I think that still exists, although the paper that we had published a couple months ago described a severity score that could be used in the hospital to say, is this patient truly mild to moderate, or are they severe, or do they have mild to moderate symptoms, but their immune system is severe on the severity score. So, we need to implement more precision medicine approaches, both in the acute COVID, but also, in long haulers, which we've been doing. And, the other thing is we're dealing with Delta right now. 80% of the infections in the United States are Delta. I was on a conference call the other day with some other experts, and Delta is progressing at a much greater rate than wild type, we'll call it wild type COVID is. And so we're even more susceptible to something that's accelerated without knowing that it's going to be accelerated. So we need to be able to, in order to triage appropriately and have best utilization of resources, know where we stand with an infection in terms of the spectrum of disease. So
I'm going to bring you into long COVID now. So when you think about the early part of the pandemic and you are looking at acute COVID, What was the trigger point that made you think about the immune characteristics of long COVID?
That's such a great question, and you're absolutely right. We've been working on long COVID for much over a year. What we found in multiple clinical trials was, we'd implement a treatment, we'd monitor it, 7 days, 14 days, 28 days, and some trials of ours would go to, 40 days or 60 days, and we even published a paper of a patient who had detectable COVID RNA at 87 days. We published that last fall. But what we saw was patients were getting better, patients were going home, but by no stretch of the imagination was their immune system back to normal. And I get it. Listen, this came upon us. It was mayhem. There was resource issues. The key was save their lives, do what you can, and get them out of the hospital. The problem is we were sending people home with a highly, highly altered immune system, number one. And number two, just because their nasal swab was negative at 14 days, and we even showed data where the plasma viral load in the severes and the criticals was negative or zero at 14 days. But we had no idea that there could be reservoirs in the body, either, as we've shown in immune cells, that harbor the virus for long periods of time, or in the case of long COVID, harbor protein in the absence of RNA for long periods of time. So yes, we recognized early on that there is a huge issue because people were going home that immunologically were not well.
Can I ask you a question here? Because you've mentioned something interesting. The issue about immune cells harboring the virus. When I was looking at some of the research with Professor Uhal, he had pointed out the non-productive infection of macrophages. So that's one of the white blood cells. So the virus gets into that immune cell. It can get in, but it doesn't replicate and produce new virus. Is that where you were finding the reservoirs of these viral particles being located?
That's such a great question and a great observation. My other colleague Paul Merrick and I just were on a phone call because we both feel that that COVID is truly a macrophage disease. I mean, the early cytokine storm is caused by pro-inflammatory macrophages, amongst other cells that are making a ton of pro-inflammatory damaging cytokines. But I absolutely agree with that observation. And the papers that are out there that show, there's RNA in macrophages in autopsies, this, that, and the other thing, you have to remember it's using in situ hybridization. And in situ hybridization is what I used in the early days of HIV to find.
Wait. I need to stop you there.
Yeah.
What do you mean by in situ?
So, you can take a piece of tissue, from an autopsy and put that tissue on a slide. And then what you use is basically a probe, which can be a small piece of RNA or a small piece of DNA. And then, introduce that into a cell on the slide. And if it binds, it would produce a signal that would say, SARS-CoV-2 RNA is in that cell. The problem is when we do this, quote, in situ hybridization, it's to a small piece or a fragment of the virus. Just like Dr. Uhal said, it by no stretch of the imagination tells you that virus is replication competent. And I think a lot of and then, when we started looking, there was a reason why I looked in monocytes, and that what came out of HIV and all our subsequent work after that. When I was doing HIV research, in the intermediate, there's three categories of monocytes: classical, intermediate, and non-classical. And they all have different functions, and they all express different receptors, okay, which confer those functions. When in HIV, what we were seeing is that HIV could infect intermediate monocytes because it expressed high levels of CCR5. Classical monocytes express very low levels of CCR5, which is the HIV co-receptor, but they express high levels of ACE2. Conversely, the intermediate cells produce lower levels of ACE2, but they produce high levels of CCR5. And of course, we found HIV there. We later on went to find out that those cells expressed CD81, the receptor of hepatitis C. And in 2009, we published a paper that those cells harbor hepatitis C. There's other papers that have come out that those cells are involved in dengue fever, Zika, Borrelia in Lyme. And, and then of course, there's the non-classical monocytes that express no ACE2, a little bit of CCR5, but they express the fractalkine receptor. And they're phagocytic, so they will engulf dying off infected cells or even free S1 protein if it exists, and then present that protein for months and months and months. And through the fractalkine receptor, bind to blood vessels and cause the vascular inflammation that we published 2 months ago as being really the cause of long COVID.
Wow. So let me just dig into that here a little bit. And let me just clarify something. When we're talking about these monocytes and macrophages, these are specific white blood cells.
Correct.
They're different from the very basic, almost pawn white blood cells, which are like the neutrophils. So these ones are much longer living white blood cells and can live technically the whole lifetime in some tissues. One of the questions that I'm interested in then, in terms of the classical versus the intermediate monocytes, is that there was a paper done by Dr. Rudra Channavaria with regards to looking at SARS-CoV and MERS. And what they found was that there was a very high accumulation of immature monocyte macrophages in the lung tissue very early on in the infection. Mm-hmm. Would these be the intermediate ones? It wouldn't be the classical. So what would they be?
Right. That's right. So as they differentiate and migrate into tissues, they take on a more macrophage-like phenotype. In fact, the CD14 positive, CD16 positive intermediate monocytes used to be called circulating macrophages, because they were starting to bring on characteristics of macrophages. And indeed, from a lot of the anatomic pathology studies of lungs in acute COVID, it's littered with macrophages. And like I said, Paul Merrick and I are true believers that the macrophages are really instrumental in a lot of the damage that's being done in acute COVID. And that's why, we published and we feel strongly that using CCR5 antagonists, which reprogram the macrophage from pro-inflammatory to more of a good macrophage in an effector cell, is instrumental in treating both acute COVID, and we're seeing great success with CCR5 antagonists in long COVID. And I think that's one of the reasons, along with the fact that CCR5 inhibition of CCR5 could prevent innate immune or prevent Treg cells from inhibiting the innate immune response, blah, blah, blah. But I mean, that's all on basically our first publication that came out of acute COVID. But yes, macrophages are instrumental across the board in this disease.
So in terms of what people are seeing with long COVID and the whole variety of symptoms, I mean, I was looking at a paper recently with over 50 different kinds of symptoms.
I think in our paper we had 30 of the the most important ones. And then I think there's another paper that did something like 215, which after, we're up to 8,000 long haulers in our program now. I truly believe that it 215 is probably spot on in terms of the variety of different symptoms. But as we've been seeing with treating, by inhibiting the migration of these non-classical monocytes with CCR5 antagonists, and also by inhibiting their binding to the endothelial wall with statins, we're seeing, these cells eventually they die off, because what you're doing is you're blocking their senescence program that allows them to be long-lived, and then we're relieving the inflammation. What's very interesting is all these associated terms that they use in long COVID, POTS and dysautonomia, and other descriptive diagnoses coming from specialists. I mean, those resolve when you resolve the inflammation. And that's what's been truly remarkable is, we can have people monitor their heart rate as soon as we get their immune system back to normal with our protocols. Then what we do is their heart rates return to normal. They don't have the POTS or, their, VEGF, which is elevated in probably 80 to 85% of long haulers. Once that goes down, a lot of the neuropathy symptoms go away. So again, I think we're seeing some really interesting findings in terms of when you normalize the immune system, a lot of the symptoms take care of themselves.
So,
go ahead.
Yeah, I was going to ask you, because we had with us at the conference, we had Dr. Shetty, and he's in South Africa and quite practical with the approaches that he takes. And one of the things that they were finding was that he was finding that quite a lot of the patients responded to antihistamines. How does that fit? Because did you find any involvement of mast cells, or is it purely a macrophage disease?
You know what? We obviously mast cells can become activated and produce cytokines themselves. In fact, a lot of the cytokines that we see elevated are produced by mast cells. However, we have a lot of patients who come in who have tried, the antihistamine famotidine protocol, and just they don't get better, or once they go off of those, the symptoms come back. The whole goal of what we do through IncellDx and through our program is we're treating the cause. And again, it took us a while to figure out what that might be, but it's, when you treat the vascular inflammation and you treat, the fact that it's caused by the circulating, monocytes carrying S1, when you treat that, you're treating the cause. And when you withdraw from therapy, which is sort of our second phase, they have long-term symptom-free, and then we still monitor them for relapse. But fact is, we've been able to get people to long-term symptom-free. And what we do is we step up, once we return their immune system to normal, we step up their exercise while on therapy. And then if they tolerate that well, which they never did because they all have post-exertional symptom exacerbation, then we withdraw therapy and then see how they're doing, and we follow them.
I'm going to pause on a point that you just mentioned there that I had found fascinating in the conference. This connection with exercise and patients getting worse with regards to exercise. What is that about?
So that's actually in the discussion of our latest paper. And that was something that was fascinating to us. But exercise actually mobilizes these monocytes. And, once we get them on therapy, they start to tolerate exercise better. And I think what we're doing is we're really, number one, we've done serial sampling on multiple patients on their S1 protein and non-classical monocytes, and eventually on therapy they go away, and as they go away, they're able to tolerate exercise. And I think, from the physiology journals, we found 2 papers that showed that these monocytes are mobilized by exercise. So it really fit into our hypothesis. And I have a couple slides I can show you, whenever we get a chance, that will show you what we think is going on in terms of both exercise and this fractal-kind pathway.
You can bring it up now. If you just click on share, I should be able to see it. You can choose to share your window or to share the whole screen.
Okay. Can you see this presentation?
Have you clicked share as yet? It
Yes.
will appear. Click it. Just make sure you've clicked. Yeah.
Entire screen.
And then have to click the share.
Share.
It's down at the bottom.
There we go. Can you see that?
No, I still don't have it here.
Share entire screen. Share tab.
And down at the bottom, you'll see a button to say share.
What do you want to share? It's not coming up as something I want to share.
Okay. We can come back to that in a little bit, if anything.
Yeah,
So let me explore something here a minute, Bruce.
Okay.
You mentioned about the issue about exercise, and it made me think about one of the things in my mind that's a differentiator. Do you consider long COVID versus complications of COVID? How do you look at that angle?
Yeah, I mean, I think it's a good point because it all depends on what their acute picture looked like, and frankly, I don't recall offhand, after seeing thousands of patients, of talking to a patient who says, "Well, I was in the ICU and I was intubated, and now now I've got long COVID." I mean, I would say in general, they had mild, maybe moderate disease, but like I said, maybe only a handful who had severe or critical disease. And it started us thinking that these people were probably not treated at all. So no antivirals, no steroids, no whatever was available at the time. Although I don't think steroids is necessarily something that is good for establishing long-lived reservoirs. But nevertheless, I think the majority of the patients that we see had an unremarkable acute phase.
Now, the reason I asked that question is because when I look at some of the patterns that I've been seeing, is that when we speak about long COVID, I usually say, firstly, because we know that there's a degree of cardiomyopathy that can occur, because we know that there's a degree of lung fibrosis that can occur. Some patients may have problems with exercise, and therefore you wouldn't be surprised if they struggle with breathing.
Sure.
Additionally, you have some patients who just feel short of breath even when everything looks normal. And the question I've always asked is this more to do with pulmonary hypertension, because that's where the whole renin-angiotensin system is concentrated in the lungs. Anything that has reflected that in your research?
We obviously there's patients who have a number of different comorbidities, and there's some that have long-term damage from acute COVID. But I'll tell you, the shortness of breath thing is something we get very often, and what I tell our patients is, I bet your pulse ox says your oxygen is in the 90s when you feel short of breath. And they said, how do you know? I said, because shortness of breath, I believe, is because the pleural sacs where the lungs sit, the diaphragm, maybe even the periosteum of the sternum are all inflamed, right? So it's the mechanism of breathing that feels restrictive, yet their oxygen exchange is fine. Yet they quote, feel short of breath. But I think that shortness of breath is because of inflammation in the mechanical aspects of breathing that gives them the impression that they can't get a breath, as opposed to actual oxygen exchange.
Interesting. I'm going to bring a question in that I've got from John here. He would have asked this, I think, in the conference. Thanks, John. So is long COVID pathophysiology the same as ME and chronic fatigue syndrome?
Thank you for that, John. It's very timely, and I think from the minute that we finished that first conference, I mean, we've opened up our program to post-vax individuals who have long COVID symptoms. We've opened up our program to post-Lyme. And, we have started to see, we opened up at least the testing portion to ME/CFS. The reason being, we've gotten so much information about the symptoms being similar. And, I don't know that the pathophysiology of the disease is similar. I know for a fact, for instance, like post-Lyme, there are papers out there that show that the Borrelia peptidoglycan is actually in intermediate non-classical monocytes and can traverse all over the body through the blood-brain barrier, cause vascular inflammation. We've treated probably 10 post-Lyme disease patients, and they've all responded to the protocol that we use for long COVID. I'm telling you, on a call the other day, I had a post-Lyme patient who had been taking our protocol for maybe 5 days, no more than a week. And he said for the first time in 10 years, he was able to swim. And he was emotional, as was I. He basically said, I thought I would never swim again. And, thanked us for looking at post-Lyme. And so, yes, I think the pathophysiology of post-Lyme, in that they're carrying antigen in the absence of, potentially in the absence of replicating bacteria or bacterial nucleic acids, is very similar to what we're seeing in long COVID. Now, we've just started to look at ME/CFS patients. They have a similar pattern of inflammation that we don't have enough patients yet to put that through our machine learning and AI yet, but we will. We're about to come out with a paper on the post-vax immune profile, which we have done the bioinformatics on, but eventually we'll get to that with ME/CFS. And I think I'm excited to see, exactly what's going on there. Now, it's always been, attributed or associated with chronic herpes virus family viruses, not just herpes simplex, but herpes family viruses, CMV, EBV, varicella, Epstein-Barr, HHV6. All of these, have been investigated to some extent or another in ME/CFS. So it's potentially a different pathology because those are truly latent viruses that have the ability to reactivate. From what I've seen with COVID, it's number one, it's an RNA virus. They typically don't have a true latent phase where they will reactivate and come out. So I'm not seeing any evidence of reactivation of COVID. And now that we can do whole genome sequencing and look in a variety of different tissues and cell populations, we're adding to our database of information in that regard. But to answer John's question, we're still at the beginning of seeing immune profiles from ME/CFS. I think we're probably 5 or 10, but we'd be really happy to report back on that, when we have some significant numbers.
So there was a point that you made that I immediately thought about, and I was waiting for a pause, and then somebody asked the exact same question here, which is this. You mentioned post-vax symptoms. What is that? And what have you been seeing?
Yeah, I mean, this has been truly fascinating, and I want to throw out the caveat that it's a very low percentage of individuals who have been vaccinated. However, even a low percentage of 150 million in the States is a large number, and we're getting bombarded with them. Thankfully, because I think we know what it is, and we've been treating it successfully, and they tend to respond better to our protocols or quicker than long COVID. But what we found is, like I said, when we've done 50 that we've actually put through our bioinformatics programs. The parameter importance is slightly different than long COVID, but at the end of the day, the computer categorizes them as long COVID. Okay, having never had COVID, nucleocapsid antibody negative, etc. So then we looked at the non-classical monocytes. They indeed have S1 protein in non-classical monocytes. We're putting this paper together right now. We're confirming that again with mass spec, just like we did in long COVID, to be absolutely sure that that indeed S1 is in their non-classical monocytes. So we do that by actually sorting non-classical monocytes from post-vax patients and from long haulers into a tube, isolating the proteins and putting them through mass spec to confirm that it's there. And so it's turning out to be very, very similar to long COVID.
Yeah.
We have found a couple of quote controls, which are post-vaccination, who don't have long hauler symptoms. We've looked at 15, and one of them has S1 protein in his non-classical monocytes. What's very interesting is his cytokine pattern is normal. So he doesn't have the vascular inflammation pattern, the CCL5, the soluble CD40 ligand, the TNF alpha elevations that are typical of post-vax immune profiles. So we're investigating that, in terms of why. And one of the things that we're looking at.
Oh, before you say that, Bruce, Kenneth has put a question here that I was thinking about as well.
Yeah.
So why are these non-classical monocytes picking up the S1? Is it? I'm trying to think about it, because when we put it in the mRNA in the muscles, it's supposed to be picked up by the dendritic cells and taken to the lymph nodes.
Yeah.
Is that where that would occur?
Well, I think people are misunderstanding. We're looking for S1, right? We haven't done a whole proteome in these cells to say, is there any other COVID proteins in there? But the fact that S1 is, I think, induces significant inflammation is why we started with S1. I think ultimately we'll get to the point where we'll do, full proteomics in these cells and see if there's any other proteins, much like we did for COVID RNA and only found fragments. But for right now, we're finding S1 because we're looking for S1 is the answer. Could there be other COVID proteins in there? Sure. But I don't think any are as immunogenic as S1, and that's why we had a particular interest in looking at that.
Interesting. I'm going to raise a question that I have noticed anecdotally. I keep on saying it, and I don't think people fully believe me. But from my clinical experience, I have come across many patients who have, as we would say, the either long COVID or the chronic fatigue kinds of syndromes. And I have noted that a significant proportion of them have associated gastrointestinal symptoms, IBS type symptoms, constipation, diarrhea. Is there any link with what you are seeing with regards to these macrophages, monocytes, and this GI system?
Well, funny you should mention that. I mean, it was something that obviously we addressed during HIV as well. The gut mucosa harbors 98% of your immune cells. And so with immune activation, you're going to get GI disturbances. In fact, when I was on the data safety board for HPV vaccines, what was really interesting is on the 9-valent vaccines, there was so much profound immune activation that the major symptoms with the 9-valent vaccine were GI. So I think it's a reflection of ongoing immune activation and is relatively nonspecific.
Interesting. John had asked another question that I'll bring up here, which was, could coronaviruses reactivate latent viruses that cause these syndromes? Because we've seen the association with, Bell's palsy, reactivation of herpes with shingles. Yeah. How does that work? Anything that you've seen?
I agree with John, and I agree with him for one reason. When we did, we still are doing it. We're about to launch this clinically. When we looked at like cellular immune profiles, 25% of long COVID individuals had decreased CD8s. So I think there was an element of, and then of course the decreased CCL4, which is part of the long hauler index, indicates that there may be there's hyperimmunity, but there may be also some, immune, deficiencies in terms of keeping, some of these chronic latently infected viruses at bay and seeing reactivation. So, again, another diagnostic dilemma. I mean, they go to the physicians and they get an IgG and an IgM. In my experience in over 25 years of pathology, IgM with chronic viruses is a terrible marker of activation. Absolutely terrible. You can't rely on it. And so what I was doing at Stanford was RNA DNA ratios. I mean, these are DNA viruses, right? And the only way you could tell if they're being reactivated is if you do serial quantification of these viruses. Then the next big question comes up, quantification of what? And what's the denominator? Is it plasma, serum, T cells, B cells? No one really can agree on that. So when I was at Stanford, they were busy working on CFS, which was amazing, and then looking at CMV, and I actually have, a close family, relationship to CMV and chronic fatigue. But you know, one of the things was we quantified CMV out of plasma, and you know, then you had to so sometimes it would go from, well, it went from 1,000 to 5,000, okay. Then you have to explain to, you know, some physicians that the inter-assay variability on nucleic acid quantification is half a log. What is half a log? 5 times. And I would say, I can't tell you with statistical certainty that 5,000 is different than 1,000. Okay? This, again, is part of this global issue with everybody so involved in their healthcare and interpreting their own lab results. And if they saw, wow, my CMV viral load went from 1,000 to 5,000, give me some ganciclovir. And I would say, wait a minute. Interassay variability is exactly half a log. That may be elevated, may not be elevated, okay? That is the problem in this internet social media world. I mean, we have people who are sharing their test reports with the world and saying, oh, you know, look at me, or this fits, or this doesn't fit, or what. And I'm like, no, that's why there's pathologists in the world to interpret these things, right? But to get back to the answer to John's question, yes, I think that does happen. The problem is I'm not getting the information to say unequivocally that it is happening. You know, I'm getting a bunch of IgG, I'm getting, you know, some IgMs, and serology with chronic viruses is you know, you're in the, you know, there's no man's land. And again, that's why at Stanford I was doing RNA to DNA ratios. The RNA would indicate that the virus is actually active, transcriptionally active, and then use its own DNA as a denominator, a true denominator, so that you could look at RNA to DNA ratios and say, wow, there is reactivation, or no, it's all DNA, there's no RNA, so it's latent.
Yeah.
That's where we need to go.
Yeah, somebody is asking here, when will there be any data on your program, recoveries and so on? Is that available?
Listen, I mean, people write about it all the time. There's plenty of testimonials. You know, we're just so busy right now. We're a company. We're not academia. We don't have that much time to write papers. We're writing papers as quickly as we possibly can. I look forward to putting out that data. I mean, I would say 90% are getting better. And we have some that will say I'm 98, 99% of where I was pre-COVID. I mean, that's been on the news. It's been everywhere. Yeah, we have to do that. I get that. Problem is we're in the middle of a pandemic and I'm getting 1,000 new patients a week. So, you know, I think it will come, and I'm excited to do it. I'm not trying to avoid it, but you know, we're trying to help as many people as we can, and we wouldn't be getting that many people if it wasn't working. So, you know, like I said, it'll come.
And in terms of the reach that you've got, because as you said, even being a medium-sized company, with this many people across the world that are affected, if you have a protocol that is working so effectively, how do you scale that out to the rest of the world?
Yeah, well, that's a great question. And we are launching with a major reference lab that's based in Spain, literally a week or two from now. They're a great partner. We've been working together. They were approached by the Spanish Long COVID Association that literally said, we need you to go live as quickly as possible. I mean, think about it, about a patient base pushing a multi-billion dollar company, not us, the reference lab, to get a test launched, you know, so that they can I mean, the advocacy groups have been incredible. So, and they've helped push this along. And, you know, Europe, usually in August, Europe is, quote, closed, So despite that, we're very close to launch there. The great thing about this lab is not only its reach is unbelievable, covers all of the EU, covers the UK, covers Mexico and South America, so that the test will be available, in that part of the world. We're starting to have discussions with Asia, Southeast Asia, but for right now, we're really focused on the EU, UK, Mexico, and South America, where COVID's hitting badly. And getting that lab live, we're bringing on Spanish-speaking telemedicine physicians, eventually, French, German, whatever we need to do, we're bringing that on. So we're scaling that. And then the great thing is this lab and Italy. Don't worry, my wife's family's from Italy. I would never forget Italy. I was married there. So anyway, so we're launching globally, and we're scaling, and we are, obviously right about to raise some money. Even though we're profitable, we're raising money to be able to scale this effort globally, to, because I think you're right, Philip. I think this is the tip of the iceberg, and this protocol is working, and we need to get it out there as quickly as possible.
And so for the case of countries that don't have access to large quantities of funds and can't afford high prices, what do they do? Do they just sit at the back of the line as usual?
No. Yeah, and the reason is, yes, we're now getting data on, we probably have 5 or 6 different cocktails that we use, and a lot of them span the spectrum of drugs. But I think, something that's minimally expensive is, for instance, ivermectin with, Prevestatin or the statin of your choice. I think that's a relatively inexpensive protocol, yet very, very effective. And then, of course, we add, CCR5 antagonists, which is our brain fog tinnitus killer. That just takes it away, immediately. And tinnitus has been really, really debilitating to so many people. And I have a little bit of it, but, not from COVID, probably from, too many concerts. But, it's something that is really annoying and affects people on a day-to-day basis. Hello from Chicago, my hometown. Hello. Do you have a question? I love that we're getting some hometown people. Bring me back from California, please. Anyway, so we are, we're number one, we're advocating, we're talking to congressmen, we're talking to big philanthropy groups. We started a GoFundMe page for people who can't afford some of these diagnoses and therapies. We didn't start it, somebody else started it, and we're 100% on board with that. So every time I give a talk, I'm out there saying, listen, these people are disabled, they need healthcare coverage, and they need and a lot of them are out of work. They need some financial benefits as well. This is going to be a healthcare, if it's not already, a healthcare emergency, but also an economic emergency. And people don't get the magnitude of this, of long COVID. And of course, listen, what's happening with acute COVID, the numbers are just going crazy. And I know we're going to start seeing, long COVID Delta, patients sometime soon. But we have to address this much like we're addressing acute COVID, because I think with the numbers involved, it could be just as much of a resource issue and a personal issue as well.
So Tanisha has just asked a question from Chicago, just as you asked. Are you either seeing eye infections or eye inflammation in long COVIDs? And well, we mentioned the post-vaccine events, which are not so frequent, but what about menstrual irregularities and so on? Anything?
All of the above. And I think, especially not so much eye infections as visual, different visual abnormalities. Of course, obviously, the blood vessels are highly vascular. VEGF is problem in macular degeneration, diabetes, and causing neovascularization in the eye. So we know that a lot of the factors that are involved in long COVID and maybe even post-vax are going to affect the eye. So absolutely yes. And the menstrual cycle issue is very interesting because some people get better, some people get worse. The menstrual cycle is driven by cytokines, so I'm not surprised. We haven't looked at enough of those cases, but we certainly hear, a handful of those stories about, oh, my long COVID symptoms have been great, but as soon as I, got my period, then they got worse, and then they got better, and there's just, and that's the thing about cytokines and chemokine receptors, is these are exquisitely regulated and dynamic. And that's why the desperate need for precision medicine to be able to, analyze the effects of certain therapeutics. And that's something that we're looking at right now. Well, why do some of the post-vax, this one guy, why do we have, he has post-vax and high S1, but absolutely normal cytokine profile. So we're looking at fractalkine receptor expression and fractalkine receptor polymorphisms. Just like in CCR5, there's a delta 32 deletion in addition to different polymorphisms of the CCR5 receptor. Something very interesting that we found, and it's in opposition to a paper that I believe came out of Europe, is that the delta 32 CCR5 is protective of severe COVID disease. The paper out of Europe associated delta 32 with a variety of different symptoms, which is different from how we did our study on 400 patients, where we actually looked at the CCR5 delta 32 based on the classical acute COVID definitions. Okay, so normal individuals, mild to moderate, severe, critical, and long haulers. And what we found is in the normal population, the prevalence of the delta 32 deletion is about 9%. In mild to moderate and long COVID, it's about 20%. In severe disease, the prevalence of delta 32 is 0.8%. So there does seem to be a protective effect of delta 32, which would fit in on our early work, which showed that the CCL5 pathway was involved in acute COVID pathogenesis. By the same token, the fractalkine receptor is another chemokine receptor pathway, and undoubtedly that may be involved in the magnitude of vascular inflammation because it's intimately involved in the binding of these non-classical monocytes. So we're actively looking at that as well.
Wonderful. I think we're coming close to our end now. We've spoken for about an hour now, which is quite remarkable. Some of the concepts are mind-blowing. Again, John is throwing in more questions with regards to low-dose naltrexone, hydroxychloroquine, ivermectin, IV glutathione. I think John has got a whole mix of stuff here. So I think the one that I took from you is the fact that you mentioned ivermectin, which does seem to be a drug that nobody wants to talk about these days. But it certainly seems from your experience to be having an impact on long COVID.
It has. We use it in our cocktails. we find that much lower doses are just as effective. We use somewhere 6, 9, or 12 milligrams every 3 days with with the CCR5 antagonists and statins, and that's been working really, really well. There's some people who don't tolerate ivermectin and just go on the CCR5 antagonists and statins. They tend to do well. I do think the ivermectin does help reduce cytokines and has immunomodulatory effects and also potentially effects on presentation of antigen. Again, we haven't had a chance to look at that. We like ivermectin. I think ivermectin and pravastatin has been very successful in post-vax and in individuals who can't afford either fluvoxamine or Maraviroc as part of our our big protocols in long COVID. So yes, and then as far as some of the other agents that John mentioned, I've seen a smattering of those and people coming in who've used them and say one thing or another. I think glutathione is a really interesting metabolic pathway that and is part of something we're starting right now, which is we're bringing in this nutrition aspect to our chronic COVID treatment center and our www.covidlonghaulers.com program. There'll be ultimately a button that will allow you to get a nutritional consult, because I think a lot of these individuals just haven't been able to eat or eat correctly or provide their body with a lot of the metabolic things that they may be lacking. And we do think that's important. We're rolling that in, and we're having a meeting next week in that regard. So I think nutrition and some of these supplements are important. But for the most part, what we're doing right now is treating the cause and getting their immune system back to normal. And then we'll treat what's left over.
So great. We're coming to the end now, Bruce. So what do people do if they need help now and you seem to be overlooked? What do? Do they go to the IncellDx website?
Yeah.
What options are there for them?
Great point. We're not overloaded. I mean, I think that's the number one thing, and we'll scale as we need to scale. www.covidlonghaulers.com is the place to start. It leads you through testing, telemedicine, etc. If for some reason you're not getting a response, but that's rare now, and maybe 4 months ago that was true. info@IncellDx.com, and then we're going to set up a separate website, separate telemedicine physicians, basically the same boilerplate in Europe, and that includes the UK, and then of course Mexico and South America as well. So we're just going to stamp it in each region, and I think we'll be able to replicate it easily, because the hardest part of anybody would be manufacturing of the reagents and the kits for the diagnosis, and that's what IncellDx is good at. And and I think we have now the experience with the telemedicine aspect and the patient support aspect, and we'll be building that out as well, globally now. So it's exciting, and we're really thrilled that we can get this around the world.
Excellent. Perfect. And thank you very, very much, Bruce. Really appreciate having you on. Thank you, everyone who has been with us, and we look forward to our next major conference, which is coming up in about 2 weeks' time, on treatment options with regards to COVID-19. Exciting group of speakers. We're looking to build a panel as well, and so look out for that in the near future. So thank you again to everyone, and we'll just say goodbye now.